So paying providers of long-term care. Now, this is just one simple model, and I'm not going to develop the full model, but the big question is, we want to create a payment system or that actually makes access easy for different groups. And we also want to have high quality, and we want low prices. And we're going to look at or just one model with some implications for these three things. Okay, and the model we're going to look at is developed by Scanlon and it's published in 1980. Let's just assume that the providers, they maximize profit, and let's just examine one payment system, which is that you pay them, you pay the providers a certain sum, let's call it R, for every single day that they accept a public patient. So you have a dual model. You have private, the institutions can accept private patients, but they can also accept patients from the public system, and if they accept a patient from the public system, they will get R. So that's like a fee for service or a fixed per diem payment. Every day they can get R for a patient. Per diem payment. But if they take a private, admit a private person, they will get P, the price, per day. So it's a dual model, dual markets. And let's also assume that they maximize profit. The profit in this setup, let's say you also have, now you have a fixed number of beds here. Let's call that X bar. That's the number of beds you have available. And you're trying to maximize profit. So what is your profit then? Let's write down the function here. You will, if you provide these beds, your profit will be the number of beds you give to the private, which depends on the price you can achieve, times the price you will get in that market, plus the number of beds you give to the public, for example Medicare. So the number of beds is going to be the number of beds you have available, subtract the number of beds you gave away to the private sector here, and multiply that by the price you're going to get in the public sector. And then you have to subtract the cost of every single bed, and let's say it's the same cost there as for all the beds. So that's your profit. Now, just this very simple equation here has some implications for access, quality, and prices. First of all, so let's look at implications. First of all, you will have cream skimming, because in this system you get R for every single person you admit, but then of course it will be good to only admit the patients that are easy to have in your institution. So you will take the easy patients and be difficult to get access for the difficult patients. Okay, so cream skimming, that's what we call that. Second, if you're this kind of institution, you will give places to private people who are paying, and then use the spaces you have left for Medicare. So as long as they're willing to pay more than Medicare is willing to pay, they will get a place. So access to private will be ensured, and Medicare will usually have a waiting list then. For Medicare patients, or for public patients coming from the public. So that's, with respect to access, we can say that based on this profit maximization thing, if they actually do that. Now, what about quality then? Can we say something about quality? In order to say something about quality, we need to add quality to the equations here. And let's say demand here, X, depends on price and quality. Times price. And the same with X here would depend on price and quality. And also cost would depend on the number of beds and the quality that you provide. So it's basically the same thing here, but whenever we do something, the demand here is a function of price and quality, and cost is a function of quality as well. Now the important thing then is, and this is the one key implication, third implication here, that the quality will depend on how sensitive the demand is to differences in quality. So the sensitivity, or what we call the elasticity of demand, so the quality will depend on the elasticity of demand with respect to quality, which makes sense, because if people care a lot about quality, then you will respond to that and provide high quality. But if people do not, then you will not provide high quality care. Now this has one surprising implication in this framework, because if you increase R, the payment from Medicare, then quality may go down, because let's assume that it's only private demand that responds to quality, and public demand does not respond that well to quality because they don't have the same information. If that's true, then increasing R means that you will have more patients or more people in long-term care coming from the public sector or being paid for by the public sector, and they don't care that much about quality, which means that the institutions will care less about quality because they all have to give all the patients in this institution the same quality. So increasing R may reduce quality in this system, which is surprising. How could it be that you increase the amount of money you pay and that's gonna decrease quality? But it is possible in this system. I'm not saying it's gonna happen always, but it's a logical possibility. Okay. Yeah, we may call this the fourth implication if you want to. Now, there are other implications as well. These are standard. For example, if you increase competition, then quality should increase, because then your demand is more sensitive to quality again. I just want to make a last distinction, which is between perceived quality and true quality. I think it's important here that demand responds to the true quality and not just the perceived quality. And if there's asymmetric information that you can pretend to be good and you send that signal and people believe that, but you don't have to be good, then this problem will have a market still. We'll have a problem. But this is a very simple setup, and you can see you have some interesting implications still from this setup. Thanks.